great. That was really terrific. And I have your questions right here. And we're going to have a discussion between us about some of the questions. So we're going to all talk about this. First question I'm going to direct to Jay. Why isn't the eye pressure measured throughout the day and night to determine if pressure is spiking?
Why is it not?
Why is it not? Why don't we do that?
Yeah, it's a great question. I think Arsham was talking about that at the end there, is that we'd love to have all that information, but it's hard to acquire that information because the most accurate way of checking the pressure is using that blue light applanation tonometry in the office. There are some other devices out there that we use that are handheld, but they often require anesthetics, which are potentially dangerous to use at home yourself. But now there are some machines that are out there that are being sold commercially where patients can check their pressure at home throughout the day, but they tend to be pretty pricey right now. And some people can physically use the technology to accurately measure their pressure. So there's this interest now in other ways of checking pressure, including implanting material within the eye with a sensor that will give 24-hour pressure determinations, and that's an exciting area of research that we're looking at. So we recognize the need, we just don't know how to get that information easily.
So Arsham, I have a question for you. This question was about intraocular pressure, but also we didn't talk about today, but blood pressure might be a risk factor or is a risk factor for progression. Arsham, do you ever do 24-hour blood pressure monitoring, or what do you think about blood pressure?
We do. We have pretty good partnerships with our primary care physicians. So the whole issue is you're trying to pump blood through an organ to give it the proper nutrition. If your eye pressure is too high, it limits how much of that flow of blood can get into there. So it just kind of compresses against it. The opposite is true though too. If your blood pressure drops too low, then you don't perfuse or you don't bring the nutrition that the eye needs. So one of the common things that we think about if patients are losing vision and their pressures have been very well controlled is looking at what the blood pressure is doing, especially during the evening time. A lot of times you'll have patients that take their blood pressure medications at night. So that's one of the first things why your doctor might ask, well, do you take your blood pressure medicine at nighttime? We're trying to see if there's a chance that your doctor can work with you to take that medication in the morning. Those dips with really low blood pressure can cause issues. There's not a lot of great medicines that can actually raise the blood pressure. So then our next factor is lowering the eye pressure to allow that low blood pressure to continue to pump nutrition into the eye.
I actually had to learn how to work with cardiologists and internists because early on I would call them up and say, you're over-treating the blood pressure. Can you lighten up? And they'd be like, who? What? You're an eye doctor. What are you calling me for? So I think one of the take-home messages for us is how important it is for your glaucoma specialist to coordinate with the other physicians. And we do that often behind the scenes on your behalf a lot. So we do care about that. Amanda, someone has a question for you. What surgeries did you have? What was the surgery that you had as a child?
You know, I don't know what I had. I was 3 months old. It was Dr. Marshall Parks, who's now retired and passed away. I saw him for 20 years. Yeah. So finding a new doctor was challenging, but we did. I'm not sure, but my dad is here. And I will ask him later and share.
So Jay, you could probably make a pretty educated guess about what she had at how many months?
It was 3 months.
When she was 3 months old.
Say probably goniotomy is what's traditionally done, and sometimes a trabeculectomy. Those were the two mainstays of surgery for, congenital glaucoma.
So the next question is about low pressure, or sometimes we call it normal pressure glaucoma. How is normal pressure glaucoma treated the same or differently from primary open-angle glaucoma? Arsham?
So the normal pressure issue, when you talk about normal pressures, what you're saying is that the pressure that we measure is below what on average most people have. When I talk to patients, pressure is really kind of more independent of how the eye reacts to it. As Ruth mentioned before, you have patients, and some of them are even in the 30s with literally no damage. We have some that get so high, their optic nerve isn't affected, we worry that their blood vessels are gonna shut off flow. And so that's one potential reason for treatment. But there are some pressures to where their eyes are so responsive to just slight changes in that pressure, and even a normal pressure is too high for their optic nerve. They're very difficult to treat. One, the diagnosis is tricky, because if you have a patient with a low pressure, that's not your smoking gun for glaucoma being the cause of vision loss. And your doctor might recommend looking at an MRI to make sure that there's not a tumor that could be causing it. And then the other factor is, if we want to drive your pressure below normal, then you run into issues like what you dealt with, which is the pressure can drop normal and it can cause some pretty tough complications to deal with. It's a very difficult disease. I think the neuroprotection side, protecting the optic nerve, is kind of where we're looking at treating that one.
Actually, Jay, I'm going to ask you 2 questions in a row now, because Arsham brought up neuroprotection. So Dr. Katz knows a little bit about neuroprotection. So I'm going to ask you that as part 2. But part 1 is sometimes with primary open-angle glaucoma or high-pressure glaucoma, we actually diagnose it before we catch the pressure being high for a lot of reasons. So how do you tell the difference?
Between normal tension and high tension?
Yeah.
It is an arbitrary designation, So some people say, well, what number do you use? Well, you can use that line anywhere. Is there something magical about being 20 versus 23 for the diagnosis? I mean, it's a disease where the risk factor is pressure. If you're not a pressure-sensitive eye, then you don't have glaucoma. So yeah, you look for maybe an MRI to look for a tumor. Well, obviously the treatment for that is different. But there are a lot of reasons why you might have a normal pressure range and have glaucoma. You've missed, as some people have asked, a pressure of 30 in the evening because we don't check pressures in the evening. We also have learned that if you don't measure the corneal thickness, some people have really thin corneas, and if you have a thin cornea, you're actually underestimating the pressure with our current applanation tonometry, the gold standard for measuring pressure. So sometimes the diagnosis is really incorrect, and we later correct it to high tension. They really weren't normal tension. But even if it is normal tension glaucoma, all our therapy right now is directed towards lowering pressure effectively, and it's tricky, as Arsham mentioned. Sometimes you can go too low with surgery, not so much with medications. So there is a search for other ways of treating these patients. There are some people who never seem to have a pressure above, let's say, 20 and have definite glaucoma, and there's something more than just pressure going on. Pressure is important, but there's something else. And then people have looked at neuroprotective agents. In the laboratory, we've identified a lot of different compounds out there that may be neuroprotective. It's really, with glaucoma, it's really difficult to do a study in the real world to show that something is neuroprotective, because lowering pressure is neuroprotective already, and you're not going to hold back on therapy that we know works, lowering pressure. So we have to lower pressure and on top of that do something neuroprotective. But there are a number of really exciting compounds out there that are being looked at.
So this next question I'm going to read says, I will need cataract surgery at some point. Should I then get surgery for my glaucoma that's being treated with drops? And I'm going to ask both of you, maybe Arsham first, but I would just like to make the comment that sometimes I say to my patients, would you please hurry up and get a cataract? Because it is an opportunity for us to address the glaucoma, but also cataracts make your visual field testing more complex and less easy to interpret, and makes your field look worse, and we have to figure out, is that from the glaucoma, is it from the cataract? And you get a little pressure drop just from having cataract surgery alone in some cases. So Arsham, what do you think about cataract surgery as an opportunity to help out glaucoma?
Yeah, cataract surgery is a potential missed opportunity to help out glaucoma. And in today's day and age, the options for what we're working on in the drainage system, they are so by and large safe. And in many studies, they're equally as safe as just cataract surgery alone. Now, if you do enough surgery, anytime you add an additional step, there's always an added risk to whatever you do. But by and large, they're very similar to the safety profile of cataract surgery. When we commit you as a patient to drops, we have already put you at a pretty big burden for medication, whether that's just the cost, the ability to put them in your eye, and even just the toxicity to the surface. So then we've committed to the disease with you. And I think during cataract surgery, we need to address that disease because that's our opportunity. And there is something synergistic with doing cataract surgery and working within that drainage system to where we get more of an effect of lowering of the eye pressure than working in one of those alone. And there's many reasons for that. But that's the time in which I say, if it's time for cataract surgery, we should address your glaucoma if I've already committed to having medications on board.
Jay, do you have anything to add to that?
Well, I've been in practice for 30 years, so I have a perspective now of how surgery's evolved. And so on both levels, cataract surgery is amazing surgery. Yes, surgery has risks, but compared to what I was trained to do 30 years ago and what's done today, the safety level is just skyrocketed. It's just a much safer operation. And I talked to some of you earlier where you said maybe I waited too long to have cataract surgery, and it's more difficult, and in glaucoma it can be really tricky as well. So I think cataract surgery has evolved to an unbelievably, incredibly safe level with great results. And same thing now with, you're hearing with the surgery for glaucoma, the surgeries that are being developed now, the real attractive aspect of it is the safety value. In the old days, we had trabeculectomy and then tube shunts. Great operations, but also some really significant risks. And I think with the newer glaucoma operations, you really cut down the risk profile tremendously. So that's something to discuss with the patient, though. There's some patients do fine just with cataract surgery alone, and the pressure may be even a little bit lower. But other people really do benefit, perhaps, by combining the two operations.
Really, Amanda, I think your story illustrates this about how your pressure was too low and you had to have a reoperation. But trabeculectomy continues to be a very important tool for us and was the right procedure for you. And since, Jay, you have a more than 30-year history, can you just comment on the continued role of trabeculectomy and management of glaucoma?
Well, listen, I know that there's some people sitting out here that have had trabeculectomy done, maybe even many years ago, and it's really saved their vision. I mean, it's a wonderful operation, and the people that have a great result maintain their vision. But there is a price to pay. There is that element of concern about whether the pressure is too low, whether you get infections even years after the surgery. So there is this concern, and that's the reason we don't tell you to have a trabeculectomy as the first step in your treatment. Not that it's a bad treatment, it works really, really well. And sometimes you find out that's the best treatment for you, but because of the risk profile, we don't intervene as the first step. And now we have these intermediate operations that may be tried even before you get to the big gun operation like a trabeculectomy.
All right, every person who's had a visual field test is going to love this question. When will we be able to do our own visual field tests at home? How accurate are visual field tests? They seem very noisy. And I'll just comment, and we're going to all respond to this, but I'll just comment that about visual field testing is we know it's not perfect. What's really interesting about glaucoma, unlike a lot of the other eye diseases, is that we do not make the diagnosis with one test or one modality or one thing. Diagnosing glaucoma and monitoring it over time is extremely complex, and visual field testing is just part of that. So that's one tool. And in some patients, I rely more heavily on a visual field test and less heavily on something else. In other patients, the visual field test I rely very heavily on. And visual field testing also, there are different ones we can do. We can do tests that measure out a little farther in the field, and then we can do testing that just tests the central vision really, really meticulously and closely. There is some visual field testing being developed, a couple different kinds of things, but the one I'm most interested in, because I've raised a bunch of boys, is the virtual reality visual field testing. That there are some being developed for use in the office, and then the idea that maybe we could take them home and do it at home. And the reason as a clinician I find that really exciting is that often you need multiple visual fields to really know whether some of the stuff is noise or whether it's true progression. And so the idea of sending you home and saying, could you do 5 visual fields over the next 2 weeks and, upload the results to, electronically for me? That would be incredible. I'm pretty sure none of you want to come and do 5 visual fields over 2 weeks in my office. But would either of you add anything to that?
I tell my patients it is such a boring video game, but it's an important part of it. Now, if you worry about how reliable were you on that test, we have ways that we can identify how reliable you took the test, so don't stress about it. I can't tell you that enough. Don't stress about it. The test is designed to try to trick you. If it were predictable, everyone would score a perfect score. But it really is our best way to kind of determine how things are functionally working with the eye and how you're seeing your peripheral vision. And remember, a lot of times when that disease starts, you don't notice it until things are really too late. And so it's our best way to detect these changes early so we can address the disease earlier in that process. And we all realize it's not a good test. I mean, we've probably all taken it ourselves just to get a glimpse of what it's like, and it's not fun. We get that.
Yeah, the only comment I'm going to make is that at the last Glaucoma Research Foundation meeting, the Glaucoma 360, there's a lot of really brilliant young folks working on developing technology to do home visual field testing in a simple way and that can be easily repeated. So what your wish list may be met fairly soon, where people can do multiple fields at home. And obviously, who cares what the pressure is? Who cares how the nerve looks? You want to know how your vision is doing. And really, we need that information. And just like multiple pressure readings throughout the day, you'd like to have a lot of visual fields, which are just too difficult to do in the office. So if you can do it at home in an easy way, and people are working furiously on getting a home system out there.
And even looking at artificial intelligence technology, there's a whole slew of people using computer modeling, looking at sometimes hundreds of thousands of visual fields, to the point where the machine can predict patients that might have worsening of their visual field based on their first or second visual field it's taken. There's certain patterns that come out that the machines have identified, and I think that's really exciting, promising stuff.
So I used to teach at University of Illinois, the ophthalmology residency program, and the residents would rotate through my glaucoma clinic as first years, so when they're pretty green, don't really know what's going on, and then as third years, just as they're graduating to go out and become ophthalmologists. And I had a test. To graduate from my clinic, you had to take a test. And the test you had to take to graduate was you had to go take a visual field. Because I wanted every ophthalmologist coming out of University of Illinois to know what it feels like to take a visual field test. Oh my gosh, what a moaning and groaning day that was. They acted like, it was the worst thing ever. So anyway, if you practice in a doctor from University of Illinois, they've taken a field test. So a question for both of you, Jay and Arsham. So, our patients are on the internet consulting with Dr. Google. And how do you handle it when someone comes in with the, newest procedure? I want this procedure. I read about this. And this is the surgery I think that's right for me. Now that we have so many choices, does that ever happen to you?
Hashtag fake news. No, it's one of those, you do see it and you have to be mindful of it. And in fact, I'll even look at patient portals just to see what's being said, because I think it's important for us to have an understanding of what's happening in the background. There are times when people come in so strongly committed for what they want to do, and they've really done a lot of research, and that jives with what we want. I've never let a patient really push me down that route if I really felt like that wasn't the right thing to do. But, until we study every single option head to head and mask these trials, by that I mean we don't know who's in what treatment arm, it's hard to determine sometimes what's truly better than another option. And as long as it's not going to be, in my mind, detrimental, I will have that conversation with the patient as far as what they're thinking.
Yeah, I mean, certainly people bring things in. I think it's great to get information out there and people are well read. But when they point out, let's say they have advanced glaucoma with a pressure of 35, and they're asking about a procedure that was tested only in early stage glaucoma with patients that were excluded that had pressures that were as high as theirs, they're not necessarily aware of that. So, I'll explain to them that, yeah, this is a great, maybe new technology, but it doesn't really fit your profile. So you have to be careful that it's not one device is good for everybody. You have to pick and choose which ones are appropriate on staging of the disease, where you are with your pressure, what you're expecting. So I still think it's great that people have access to that information, but you have to tailor it individually to that person. And sometimes one eye might be appropriate and the other one is not for that procedure.
It's really an exciting time to be a glaucoma specialist because when we were training and through most of our careers, we had a small number of drops to choose from. We haven't talked about laser today, but we've had laser, which is a great procedures. There are several, and we had a couple surgeries. That's all we had, and now there are so many choices. It's like I talk about the palette. It's like it's like painting a picture. There's a palette of colors, and we're gonna mix them all up together, and there's no right way to do this anymore, and we're figuring it out. And one thing that I'm really excited about is I can't tell you how smart, well-educated, thoughtful the young glaucoma specialists that are coming into our field are, and it gives me so much hope for all of you. And in closing, I just want to ask Amanda one question. Sure. Because you are mothering the next generation. So what kind of hope do you have for the generation that your child will grow up in as it pertains to glaucoma?
I feel so incredibly hopeful and just excited about all the new technology and all the things you guys were talking about. It just makes me feel great. As soon as our son is born, we're gonna have him checked, obviously. But if he has glaucoma, it's gonna be okay. We're gonna catch it early, and there's so many treatment options available now and on the horizon.
Great. With that, we're going to take a break, and I just need someone to tell me how long the break is. 30 minutes. We will see you back in 30 minutes. Yeah. Thanks.